Good morning. The committee will come to order. Secretary Sebelius, thank you for joining us today for a discussion of the President's 2015 budget. It's been 4 years since Obamacare became the law of the land, and it's been a bumpy road since then. Millions of Americans are paying more for health care as a result of the law. The committee will come to order. Please take your seats. Yes, it is on. Okay. It's been 4 years since Obamacare became the law of the land, and it's been a bumpy road since then. Millions of Americans are paying more for health care as a result of the law, a trend which will only continue to spike as a result of the failed health care exchange launch. All across the country, low and middle class income Americans are seeking smaller paychecks and working less. Towns, schools, restaurants, and businesses are struggling to comply with the law, finding that they are forced to cut hours or hold off on hiring. Millions of Americans have discovered the plan they have and like has been canceled, or they can no longer rely on the care from their local doctor or hospital. I hear about how the health care law is affecting communities like my hometown of Midland, Michigan, and how families are dealing with the uncertainty this has brought them and their children. Unfortunately, and despite Republican attempts to provide Americans relief from the burdens of this law, it appears that this is a roadmap of what is to come. We now know after the failed launch of the exchanges that since the administration was unable to meet their enrollment targets and failed to sign up enough young and healthy individuals, premiums will be higher next year. The Congressional Budget Office has also found that compared to initial estimates, fewer individuals will find health care coverage through the exchanges, Medicaid, or employer-sponsored insurance. And while Democrat leaders promised that Obamacare would create 4 million jobs, 4,000 almost immediately, the CBO projects fewer Americans will be working as a result of Obamacare. In fact, the U.S. economy will see a decline in the number of full-time equivalent workers of about 2 million in 2017, rising to about 2.5 million in 2024, according to CBO. CBO went on to emphasize this would mean, and I'm quoting, the largest declines in labor supply will probably occur among lower-wage workers, end quote. Secretary Sebelius, you've stated that there's absolutely no evidence, and every economist will tell you this, that there's any job loss related to the Affordable Care Act. But the evidence is everywhere. We hear it from employers back home, from testimony in front of Congress, and we read about it in the papers weekly. The law is not working as it was promised, and yet the President's budget doubles down on this law and requests another $1.8 billion for its implementation. With so many unanswered questions, it's hard to understand how or why Congress would approve such a request. I'm hopeful you'll shed some light on those questions and provide some answers today. Basic questions such as how much taxpayer money has been spent thus far and where did it come from? How much taxpayer money will be spent on subsidies for individuals outside of the exchange? How much did the failed launch of the exchange cost taxpayers? How many people have actually paid a premium? And how many previously uninsured Americans have signed up for Obamacare? And increasingly, we must all ask the question, when is the next delay or next administrative change in the law coming? It seems not a holiday goes by without a new announcement from the administration that delays some part of Obamacare. Notably missing from this budget is any mention on how we can secure the promise of Medicare for seniors in the future. In just a few short years, Medicare will go broke. This committee has released numerous discussion drafts based on bipartisan ideas to secure Medicare for current and future seniors, some of which were included in previous budgets from President Obama. We have the opportunity now to work toward reforms that strengthen the program, and the longer we wait, the harder the choices we must make will be. We need to have an open dialogue between the administration and Congress on this, and I'm disappointed that the administration has walked away from this commitment and seemingly provided political cover during an election year rather than offer solutions. I appreciate your making the time to be here today, and I hope we can count on a more open, constructive dialogue between Congress and the administration if we're going to make progress on resolving the law's failures and working toward solutions for our nation's seniors. Before I recognize Ranking Member Levin for the purpose of an opening statement, I ask unanimous consent that all members' written statements be included in the record, and without objection so ordered. I now recognize Ranking Member Levin for his opening statement.
Thank you very much, and Madam Secretary, welcome. We really do welcome you here, a chance to have some dialogue. I hope that's what will occur. Instead of dialogue, what we've really had from the Republicans is diatribe. And we're going to see that further this week when there's an effort to take up our reform on SGR that's on a bipartisan basis and fund it with essentially the destruction of ACA. The New York Times talks about today where the enrollment is. And it's interesting, Republicans often used to talk about Part D and how it proceeded. The Energy and Commerce Committee is going to come out with a report this morning, and it's going to turn out that ACA enrollment as a percentage of projected enrollment is already better than Part D's voluntary enrollment. So I hope you'll be able to set the record straight. As we know, it's short of the original goal, and I hope you'll address that, where we are, what the figures really mean. And also you may want to comment that 3 million young adults have already gained access to health insurance through their parents' policies, which would not have happened if it weren't for ACA. I just want to give one example of what this has meant for people in this country. A person from Brighton, Michigan, in her 30s, has lupus, a pre-existing condition. She hasn't had insurance in 6 years because it was simply too expensive. She lived in constant fear of getting sick or injured. And she said, and I quote, "There are lots of things I haven't done. I used to like to ski and mountain bike, but I know that if I broke a wrist, it would cost me $10,000. It's that constant worry of what happens if." And that uncertainty ended January 1 when her new insurance plan costing $175 a month took effect. The real contrast is an ad that has been running in Michigan about a cancer patient, and I won't go into the details, but essentially she said her policy was unaffordable through the marketplace. The ad's been funded over $1 million by Americans for Prosperity. It turns out, according to the Detroit News and others, that ad and that statement together are just false. It turns out that this person will save more than $1,000 a year. So, Madam Secretary, I hope you'll use your time to acknowledge the problems with the website at the beginning and put in perspective what's happened since then and where we're going, and indeed to have a dialogue. What has been most short in the discussion of ACA has been dialogue. We welcome you here and look forward to your testimony.
Well, thank you, Mr. Levin. Again, I want to now welcome our witness, Secretary Kathleen Sebelius of the Department of Health and Human Services. Again, thank you for being with us today. The committee's received your written test statement and testimony, and it will be made part of the formal hearing record. You're now recognized for 5 minutes for your oral remarks. Thank you.
Well, thank you, Chairman Camp and Ranking Member Levin and members of the committee. In his State of the Union, President Obama laid out values that are the backbone of his 2015 budget: opportunity for all, economic growth, and security. A notion that if you work hard and take responsibility, you should have the opportunity to succeed in America. Our budget will allow our department to move this mission forward. We start with the fact that every child deserves the opportunity for a healthy start in a high-quality learning environment. And as the President has said, research shows that one of the best investments we can make in a child's life is high-quality early education. Science has clearly demonstrated over and over that the return on early childhood investments is at least 7 to 1, far exceeding any investment in the stock market. And the fact of the matter is, these investments are good for our kids, good for our economy, and good for a family's economic security. In every state, currently, the cost of child care for 2 children now exceeds the median annual rent. Our global Our budget puts a special focus on birth to kindergarten. It brings the total investment in Child Care and Development Fund to $6.1 billion, so more of our children have access to quality care. We also propose to expand early Head Start child care partnerships for more of our children. This allows us to build on the progress we're making in reforming Head Start. And by funding the President's Opportunity, Growth, and Security Initiative, we could provide an additional 100,000 children with access to high-quality early learning. Our global competitors have figured out that investing in early education makes good economic sense. China plans to increase preschool enrollment by 50% by 2020. And in Japan, virtually every 4-year-old attends preschool. So if we want our children to compete for the global jobs of the future, these investments really matter. This budget also extends and expands voluntary home visitation so we can empower our children's first and best teachers, their parents. The investments don't add a dime to the deficit. One of the ways they're paid for is through an increase to the tobacco tax, which we know encourages younger Americans from smoking. But here's the snapshot. Every day, more than 3,000 children try their first cigarette, and nearly 1,000 a day become daily smokers. So the efforts to reduce their smoking habits are imperative. These investments have broad bipartisan support from governors, from business, military, and law enforcement leaders, from parents and health providers, and can make a huge difference in our nation's prosperity. Of course, no child can learn with a toothache that his or her family can't afford to have treated. No family can save for college when they're drowning in medical bills. This budget protects the progress we're making in helping more Americans obtain the opportunity of affordable health coverage. Yesterday, we announced that 4.2 million people had signed up through the end of February, which is an increase in 29% in the month of February in the number of signups. The number of people choosing a plan every day last month also increased from an average of 32,800 in January to 34,000 a day in February. We expect that number to rise by the March 31st deadline as more Americans learn how affordable the marketplace coverage can be. We also know that we've had a total of 8.9 million people, as the last Medicaid report indicated, that have been determined eligible for either renewal or new Medicaid benefits. Now, one of our best tools also for expanding access to health care are the community health centers, which are throughout our urban and rural areas. This budget invests to help them serve an additional 31 million Americans at new and existing sites. The budget also protects our seniors by increasing investments for elder justice to protect them from abuse, neglect, and exploitation. It protects consumers with additional resources to help the FDA oversee the safety of our food supply and pharmaceutical resources. It expands the efforts to protect hospital patients from healthcare-associated infection. And because the opportunity, growth, and security mean very little when a family faces unemployment, the budget is a job creator. It invests in industries that drive our economy, innovation, science, and discovery. The investments fuel entrepreneurship and economic growth while saving lives. The NIH-funded BRAIN initiative, vaccine development, and other innovative products. Through the Healthcare Workforce Initiative, the budget expands the National Health Service Corps, enabling us to focus training dollars on the primary care workforce by expanding residency training opportunities. And for all these proposed investments, the budget makes tough, fiscally responsible choices. We'll contribute a net $369 billion toward deficit reduction over the next decade. By incentivizing high-quality, efficient care, and by continuing to reduce healthcare cost growth, strengthen Medicare and Medicaid with $415 billion in net savings over 10 years. We'll also produce budget savings for taxpayers by continuing to crack down on waste, fraud, and abuse. Every dollar we invest in the Healthcare Fraud and Abuse Control Initiative, for example, returns $8.10 in money we recover, which last year was a record-breaking $4.3 billion. Now, in many ways, the budget reflects the notion from the book of Matthew that where your treasure is, there also your heart will be. A budget is more than a ledger. It's a statement of a mission, intentions, and priorities. This budget succeeds in that mission by expanding opportunity, encouraging growth, and protecting both our families' economic security and our nation's health security. Thank you, Mr. Chairman, and I'd be pleased to answer your question.
Well, thank you, Madam Secretary. The Secretary has a hard stop at 12:15, and in the interest of time, questions will be limited to 3 minutes. I'm going to hold my questions to the end of my time and yield to the Health Subcommittee Chairman, Kevin Brady, to begin questioning. I will then recognize Health Subcommittee Ranking Member McDermott, and then we'll start in reverse order of seniority. If we run out of time before I have an opportunity to ask questions, I'll submit mine for the record and would ask that I get a timely response to those. The committee still seeks some basic information about how many people have paid their premiums, how many uninsured are actually enrolled in the exchanges, how much the launch of exchanges has cost taxpayers, and what programs were cut to pay for the implementation that really didn't work. So if we can get answers to those questions during the hearing, I think that would be helpful. Mr. Brady is now recognized.
Thank you, Mr. Chairman. Madam Secretary, you were before the committee in April of last year. You assured us all there would be absolutely no more delays in the Affordable Care Act. We've seen 8 delays since you gave us those assurances, bringing the total now to 35. So question is, I think fairly for our families at home, what other delays should they expect? Are you going to delay the mandate that individuals have to buy government-approved health care or pay a tax?
No, sir.
Are you going to delay the open enrollment beyond March 31st?
No, sir.
Is it correct that you don't have the authority to extend that deadline? The position that the Centers for Medicare and Medicaid have made, you agree with that?
I haven't seen their statement, sir, but there is no delay beyond March 31st.
Well, my question is, the law very clearly makes the case that tax credits are available only to individuals who are enrolled through the exchanges. Yet 2 weeks ago, in regulation, you deemed that individuals who haven't enrolled in the exchanges are eligible for those tax credits. My question is, what specific provision in the Affordable Care Act grants you that authority?
Well, sir, I can get you the specific site, but the authority really comes from the law, which states if a person is eligible for the Affordable Care Act and in the exchange process, then they are eligible for a tax credit. We have made it clear that if through no fault of their own they were unable to enroll, that eligibility extends to a delayed enrollment period, and they will have a special enrollment period,
Madam
which
Secretary,
we have the authority to grant.
To be very clear, the law is very plain. Only people enrolled in exchanges are eligible for tax credits, as a committee that handles the tax credits. And we know this section well. So, and maybe you could
Sir, I'd
ask
be
the
happy to
folks
get
who
you
are
the
here
statutory
today.
authority.
Your experts are behind you. If you'd like to ask them, please do. But there is no provision there.
Sir, I will get you this in writing. There is a provision that indicates that if a person is eligible, the eligibility and in the enrollment process, we can grant a special enrollment period.
I guarantee you, Madam Secretary, you won't be getting us back that provision because it's not there. And my point is, if you delayed this law because it's not workable for businesses, why aren't you delaying this law because it's not workable for our families? How is that fair?
I'm sorry, sir.
How is it fair that you delayed this law because it's unworkable for businesses of all sizes, but it's not workable for families? Why aren't they getting the same treatment?
Well, sir, we haven't delayed the law's implementation across the board. Well,
not across the board, but for businesses, large businesses, medium and small.
94% of business owners are less than 50, and the law has never applied to them. There are 2% of business owners who are in the above 100%.
Madam
they
Secretary,
have an additional year to fill out paperwork.
Madam
Another
Secretary,
2%.
It's just not fair.
All right. Time has expired. Mr. McDermott.
Wow. Take a breath. Your budget contains several proposals for structural reforms to Medicare, all of which will increase the cost on beneficiaries. What I don't see in your budget is Medicare reforms that ask providers and pharmaceutical companies to share in the pain. Frankly, that concerns me. I think there ought to be a sharing of the pain among the providers and those who benefit from Medicare. As you know, Medicare beneficiaries already spend a disproportionate share of their income on health care compared to those under age 65, and upper income Medicare patients pay more. Now, I understand these proposals, while they concern me, were put into the budget as a part of a so-called big, bold, balanced budget deficit reduction plan, one that calls for shared sacrifice among working and retired Americans, wealthy or not. So let me ask this question. The notion that completely seems to be around here is much different, that you can cherry pick those Medicare reforms here and one there, sort of low-hanging fruit, as a way to offset or to pay for the SGR. Our Republican colleagues have been talking about doing this, and I think that it's hard for that to actually occur because SGR needs to be fixed. There's not actually a documented access problem throughout the program, and it seems unconscionable to ask those with household incomes averaging $23,000 a year to pay more in order to increase payments to doctors. My question is this: does the administration support cherry-picking structural reforms which would benefit increase costs for would increase costs for Medicare beneficiaries, or are those reforms solely intended as a part of a substantial deficit reduction package with shared sacrifice for all Americans?
Well, Congressman, as you know, the President has said for a number of years that he remains hopeful for a big deal, tax reform, entitlement reform package that would put us on the path to multi-year fiscal solvency. And so I think in the context of those reforms, that is why these proposals continue to be made in the budget. But it is in the context of a major effort. Entitlement reform is a piece of the puzzle, but only a piece of the puzzle if there's additional tax reform and revenue sharing that, as you say, involves everyone.
So the White House doesn't support selecting out pieces to pay for SGR?
Well, I think the budget is a package that moves forward, and the cherry picking of one piece or another gives, as you say, undue burden on seniors.
All right, thank you. Mr. Renacci is recognized. I think you need to lean into the microphone. Yeah. I just use my chair. Yeah, these. Yeah. Wait, use yours. There we go. Mr. Renacci is recognized.
Thank you, Mr. Chairman, for holding this very important hearing on the President's budget and allowing us the opportunity to question the administration on behalf of our constituents. Secretary Sebelius, welcome back, and thank you for taking the time to speak with us today. Madam Secretary, Obamacare was sold to the American people as a bill that would make health care more affordable. In my state of Ohio, it has become clear this is not the case, as premiums, deductibles, and out-of-pocket costs have increased for a significant number of Americans, causing working-class families and young individuals to spend more of their hard-earned pay on health care expenses. In fact, I have had many individuals in my district who are now covered, who can't afford their deductibles, now questioning me as to what they are supposed to do to access health care. Mr. Chairman, I'd like to submit for the record a transcript of an interview between NBC News and Secretary Sebelius on September 30th, 2013.
Without objection.
Madam Secretary, in an interview on September 30th, 2013, you said when asked regarding Obamacare what success would look like. Your answer, and I quote, was, "I think success looks like at least 7 million people signed up by the end of March 2014. Open enrollment ends this month, and you're well short of that target. Based on your own standards, Obamacare will not be successful at the end of March 2014. What do you now call success?"
Well, Congressman, I think that in answer to your initial question, I don't know the constituents you're speaking to, but I can give you a national snapshot where private insurance rates in the 10 years before Obamacare were running at 8.6%.
Can I get you to answer that question on what is now success? Because I only have 3 minutes.
Well, success looks like millions of people with affordable health coverage, which we will have by the end of March in the private marketplace, in Medicaid, young adults on their family plan. So we will have, I think, a successful program. We have a market, we have competition, we have for the first time self-employed individuals who don't have affordable care through their work site getting affordable coverage.
So you are changing your standard of 7 million by the end of March 31st.
I said success looks like millions of people having affordable
Well, actually,
health care.
you said 7 million. I have one other question. In that interview, you also talked about deductibles, and your answer was, well, I think families can make a choice. It isn't something they can pay for. A lot of people couldn't pay their out-of-pocket. They will want a lower deductible. Can you answer the question as to how about those people in my district who can't afford a lower deductible? What should they be doing?
Again, sir, I think that the range of plans in the marketplace is more robust than the range of plans ever has been in the individual marketplace or in the small group marketplace. Some, as you know, have lower premiums in exchange for higher deductibles. Some have lower deductibles and higher premiums. But that range has never been there, nor have the millions of Americans who now qualify for some financial help to get into the marketplace had that benefit. So I meet people every day who are actually having affordable health care for the first time. They have an employer, they've never had employer-based health care, and they have an opportunity for health security for themselves and their families.
All right, thank you. Ms. Sanchez is recognized.
Okay, my mic is working. Thank you, Mr. Chairman. And Madam Secretary, I want to thank you for taking the time to appear before the committee today to discuss the administration's fiscal year 2015 budget. I continue to believe that budgets are a reflection of what our priorities are in this country, and our priorities should be pretty clear. Creating an environment for good-paying jobs that allow workers to support a family, properly funding health care for all, and protecting benefits for those who've earned them. Those should be the focus. And I'm happy to see that the President's budget does reflect some of these goals. Specifically, just some things I wanted to point out. The proposed 2015 budget gets rid of a misguided approach to change the chain CPI balanced on the back of our seniors. It expands HIV/AIDS treatment and care through investments in the Ryan White HIV/AIDS program and CDC activities. It funds the National Institutes of Health at $30.2 billion, $140 million in services for victims of domestic violence. As one of the few women who sit on this committee, I think I would be remiss if I didn't spend at least a few moments on issues that are specific to women's health care. I want to talk about Title X. It's the only federal program exclusively dedicated to family planning and reproductive health services. Publicly funded family planning services have helped reduce the rates of unintended pregnancy and abortion in the United States. And in fact, the CDC has included family planning on its list of the top 10 most valuable public health achievements of the 20th century, along with things like childhood vaccinations and fluoridation of drinking water. I was pleased to see that the President's budget calls for a slight increase in Title X funding, and I was wondering, Madam Secretary, if you agree that the investment in family planning services is a valuable one that reduces government health care expenditures in the long run.
Well, I think it's been shown, Congresswoman, that family planning and having families be able to make choices about the timing of children and the timing of pregnancy is a huge health issue and a huge family security issue, and we've made some significant strides. I would also point out that as part of the Affordable Care Act, insurance policies now will cover a full range of health services for women, which was not necessarily the case. They will be not allowed to charge women more than men, which was typically a feature in the individual market, and for the first time have a focus on women's health issues, including family planning issues.
And do you think that the increased access to affordable birth control will affect healthcare costs overall under the Affordable Care Act?
Well, what we've seen, actuaries of private insurance companies will tell you that actually having contraception services as part of their package decreases costs because they pay for fewer unintended pregnancies and sometimes pregnancies that could result in very high birth and follow-up costs. So as an actuarial point of view, it is actually a net gain in terms of overall health costs. But more importantly, it allows families to make their own choices about families and timing, and the health of the mother and the health of the child are often significantly improved by that timing.
All
Thank
right,
you,
thank you.
Madam Secretary, and I yield back.
Thank you. Mr. Griffin. I think, right.
It's
Why don't
just
you
when
come
you
up-
try to use it that it doesn't work.
Right. Why don't you come up to the...
I think a website manufacturer, website developer's been working on our mic system. I thank you for coming. I appreciate it. What I'd like to talk with you a little bit about is the issue of investments. You mentioned investments. Almost every constituent that comes to see me in my office talks about the need for additional funding, for example, for the NIH, for Alzheimer's research, for cancer research, MS, diabetes. They may talk about education. They may talk about some other program that is funded by discretionary spending. And a lot of times when people mention investments, that's what they're talking about. And I have supported increasing NIH research funding. I wish we had the money to increase it drastically. But the reality is that funding is getting pressured, squeezed out by the growth of entitlement spending. If you could look, I've got a slide here. So this is something that President Obama said in 2011. If you look at the numbers, Medicare in particular will run out of money, and we will not be able to sustain that program no matter how much taxes go up. I mean, it's not an option for us to just sit by and do nothing. Next slide. This is what I call the Pac-Man problem. I use this to explain to folks who come to visit me why the funding that they are in favor of, which often I favor, NIH funding, for example, why it's under pressure. And it's under pressure because the yellow part, which we recognize as Pac-Man, is continuing to close its mouth on all the stuff that you refer to as investments. And HHS Secretary, after HHS Secretary have talked, both administrations, Republican and Democrat, praised their budget as fixing the problem. But the problem persists, and I just invite you to work with us for real reform on Medicare to fix this, and I would welcome your comments on how your budget will address this problem.
Well, sir, I would welcome the opportunity to work on a serious, big budget deal, including entitlement reform, but also including tax reform and revenue sharing, and spread that equally across the board. I would say that the passage of the Affordable Care Act was one of the most significant issues of late to increase the solvency of the Medicare Trust Fund. The trustees put that passage at about a 12-year additional solvency. This budget adds an additional 5 years. So when this president came into office, Medicare was likely to go
There's some
broke in 2017.
If you excuse me, I think I'm out.
That window has now been significantly extended, and this committee
But
has
you're-
voted 50 times to repeal those
But
very
you're robbing
reforms.
Peter to pay Paul, and the seniors are bearing that burden.
All right, time has expired. Mr. Crowley.
Thank you, Mr. Chairman. Madam Secretary, thanks so much for being here once again today. I'm up here now. They moved me. Madam Secretary, they moved me up here. Sorry. I know. It's musical chairs, so thank you. It's going to take a long time for me to get up here, normally speaking, so I thank the chairman for
Yes.
this
I just
opportunity.
don't give it up. Just
Don't get used to that seat.
I'm not getting used to it. Enjoy my time here. I have very little time. The Affordable Care Act has made a great strides in improving access to quality health care, such as by closing the prescription drug coverage gap, strengthening the Medicare program, and establishing competitive marketplaces for working families to purchase insurance for many people for the first time. I'm glad that the budget sustains and builds upon these successes. I'm also pleased to see that this budget looks towards the future on improving our healthcare system, such as through the new physician workforce proposal, is growing in the need for more doctors at the same time. Projections show that by 2020, the United States will face a physician shortage of more than 91,000 physicians, growing to over 130,000 physicians by 2025, not that long from now. That's both primary care physicians and specialists. So clearly there is a need for continued federal investment in doctor training. Yet I'm concerned that some of the proposals in this budget would fundamentally change this longstanding contract and how doctor training is supported in our country. Our nation has long recognized the need for doctor training to be a shared investment between our medical schools, residency training programs, and the federal government. Medical schools have increased graduating classes, and teaching hospitals are training residents above and beyond what Medicare supports. In my home state of New York, there are almost 840 residents currently being supported by hospitals alone because Medicare can't fund these positions. Nearly 10,000 residents nationwide are in a similar situation. There's a clear and obvious demand for more residency slots even within the Medicare program, demonstrating that this is not the time to be drawing teaching dollars away from Medicare to other programs. I have introduced legislation, the Residence Physician Shortage Reduction Act, to meet the real need of adding additional residency slots in these specialties as well as in the primary care area. If you could, please comment in terms of the budget itself and the effect that this will have on teaching hospitals. I don't think this is the time to be taking away those monies. We need to be adding money to help to produce the number of physicians we're going to need in lieu of the Affordable Care Act.
Well, Congressman, I think the President definitely shares your view that the healthcare workforce is of enormous importance, and we certainly have been focusing on that since the beginning of this administration. I would say there are three major components of a significant $14 billion, $620 million workforce initiative over the next 10 years, increasing the size of the National Health Service Corps, which goes a long way to putting doctors, nurses, mental health techs, dentists in underserved communities, growing that force to about 15,000 from its current 8,800 and keeping it there. Secondly, to focus on the targeted support for graduate medical education, really, again, driving not only the primary care workforce, but specific underserved specialty areas. Currently, hospitals kind of pick and choose which residencies they will slot, and we think at this point it's more helpful to really focus on the great need for primary care, preventive care, community-based care, nurse practitioners, so that the growing population of elderly and others who hopefully will stay out of the hospital will have that kind of care. And thirdly, to continue the increase that was passed in the Affordable Care Act for primary care doctors who take Medicaid patients. And I think those three initiatives combined will really do a significant amount to increase the primary care workforce, but also to make sure that primary care docs and nurses are in the right places in the most underserved areas.
Thank you. Mr. Kelly's recognized.
Thank you, Chairman. Madam Secretary, thanks for being here today. I just want to get directly to the budget because on page 33 of the budget, it highlights or alludes to a potential large tax increase that's not defined. Now, reading from page 33, this is what it says. Even with reforms to Medicare and other entitlements and tough choices, we will need additional revenue to maintain our commitments to seniors. Now, as I read this, it looks like an open-ended discussion, but with no real specifics. What specifically are we going to do? Because we're past the rug-cutting time. Where do we go? Where do we go to get this revenue? What taxes are going to have to come about?
Well, I think, Congressman, as you know, there have been discussions over the last several years. The President has proposed a number of
and I
tax
understand it. I don't want to
loopholes
cut
being
you short. I
closed.
have a very short period of time. Listen, we're playing ring around the rosy with this. There is no way that we can look at the metrics of this and say this is going to work. My question is, because the real choice right here is between entitlement reform or going to some other type of a tax, which I think a lot of people on the right and left are saying we're going to have a European-style VAT tax. This is going to put a tremendous burden on the middle-income folks, the lower middle-income folks, and the lower-income folks because it hits every one of them. Hard. Nobody walks away from this. Forget all the subsidies and everything else. I want to know, where are you going to get the money? Show me the money. If there's not going to be reform, show me the money. Where is the revenue going to come from? Because we know in this model, you tax it, you fine it. It's through taxes, fines, fees, or borrowing, or God forbid, just printing our way out of it. So where's the money going to come from?
Well, sir, nobody, as you know, in this administration has ever suggested a VAT tax. I think what we are eager to do is work with Congress on a comprehensive program which shares the burden, not taking it out of the backs of seniors, of the backs of poorest
listen,
Americans.
we're all
But that's always been the
Madam
proposal
Secretary, we
in
agree.
the past.
We agree violently on that. It comes down to dollars and cents. You
And
can't wave a magic wand and make this money appear. You can't do it. If we're not going to have serious entitlement reform, where is it going to come from? It's simple math. The President says it all the time. Just do the arithmetic. It doesn't float. It
Well, I would say
capsizes.
some of the most serious entitlement reform is underway right now under this administration. We have cut in half the cost trajectory of Medicare year in and year out. We're seeing the slowest growth in 50 years in the program, plus more Medicare beneficiaries coming in and more benefits. So
And
I would say that
but
it's
sometimes
underway.
it's much easier to talk the talk than it is to walk the walk. We heard this wasn't cost us anything, and now we're finding out it's trillions more than we thought. It's just not working. I'm looking at this, and the reform is absolutely necessary. I just don't see anybody walking that plank, and I don't see any specifics of this. We can talk in flowery terms about what we want, what our hearts are willing to do, but what our wallets can't provide. The question is, how do you pay for it? It has to be tax increases. It can't come from any place else. I wish it was. Just tap a magic wand and the money just magically appears. It doesn't. We are on a heck of a trajectory right here, and there's no way out of this absent real reform or huge tax increases. There's just no other way to handle it.
If time has expired, we'll try the mics again. So, Mr. Pasquale, you're recognized.
Thank you, Mr. Chairman. Madam Secretary, I'm glad that we're now all talking about middle-income people. Well, we've come a long way in 3 years. That's good. I think we're on the right trail. But let's change the pace a little bit. The commitment that the President has made to expanding educational opportunities and the investments in research and science within this budget are things I strongly support. The BRAIN Initiative is one of the investments that I think is particularly worthwhile. Today, we are celebrating what we've done for the past 14 years in the Rayburn building. All the research that's being done both in the military and the civilian on traumatic brain injury, post-traumatic stress disorder, which has now helped in many, many ways to help our kids in making sport decisions. The BRAIN Initiative is one of the investments that I think is worthwhile. As co-chair of the Traumatic Brain Injury Task Force, along with Congressman Rooney of Pennsylvania, I'm well aware of the advances that we have made in research in the brain in recent years, and how much we've learned and continue to learn. Your presence here today is very timely. As I said, the Congressional Brain Injury Awareness Day is evident on Capitol Hill. and a number of your offices are participating. The Centers for Disease Control and the CDC estimates that 2.4 million TBIs occur each year, and that 5.3 million Americans live with a lifelong disability as a result of TBI. Beyond those numbers, TBI has become the signature wound in Iraq as well as in Afghanistan. 20% of our soldiers deployed are estimated to have experienced brain injury. This is serious. What's even more serious is how many have fallen through the cracks. It is because of this Congress and the last 3 presidents that we finally have come to the point of recognizing it and stop sweeping it under the rug, and we've insisted on it in a bipartisan way. Brain injuries can impact anyone at any time. I know this $200 million commitment, which is double the investment in last year's budget, is not just coming from your department, but can you speak to the goals of the BRAIN initiative and how important it is that we pay attention to what's going on in that research? Very briefly, if you would.
Okay, time has expired, but if you'll respond briefly, and if you want to supplement in writing a longer response, that would be fine.
I would be glad to, Mr. Chairman. I would say that Dr. Collins, the head of the National Institutes of Health, has identified the BRAIN Initiative as one of his signature efforts going forward. He's assembled what he would call the dream team of top-notch researchers from a variety of institutions and mapped out really a very aggressive strategy, multi-year strategy. But the private sector will be intimately involved in this. Some of the key drug companies are at the table. There is an effort underway in the drug front to also get them involved in accelerating cures. So I would say it's a multifaceted project, and I'd be glad to get you some more information.
All right, thank you very much. Mr. Young is recognized.
Madam Secretary, thanks for being here today. I'm going to start on a couple of words of encouragement and appreciation. First, coming from the state of Indiana, know that our delegation, our governor, and the people of our state really appreciate your consideration of allowing the Healthy Indiana plan, which covers 40,000 low-income Hoosiers, to play an important role in terms of our Medicaid expansion in our state. HIP is the first consumer-directed plan for Medicaid recipients in the country, and thank you for that. Also appreciate internally within HHS, and I know this is a priority for OMB, increasing the evaluation of existing government programs so that we're focusing more on outcomes as opposed to inputs. Would love to work with you on that evidence-based approach in the future. One of the biggest concerns related to this health care law, of course, is its impact on jobs and wages. The CBO has indicated that the Affordable Care Act will shrink the workforce by the equivalent of 2.3 million full-time jobs. Teamsters President James Hoffa has said the law, quote, destroys the foundation of the 40-hour work week that's the backbone of the American middle class. Unite Here is a union representing 265,000 casino, hotel and food service and warehouse workers. And they recently published a new report, The Irony of Obamacare, Making Income Inequality Worse. And I'd like to submit this report for the record.
Without objection.
Unite Here supported what the president calls Obamacare, but they don't anymore. The report says, quote, without smart fixes, the ACA threatens the middle class with higher premiums, loss of hours, and a shift to part-time work and less comprehensive coverage, unquote. You have indicated, as reported in the press, quote, there is absolutely no evidence, and every economist will tell you this, that there is any job loss related to the Affordable Care Act. You know, based on the growing body of evidence, including this report, have you rethought whether or not the Affordable Care Act might, in fact, adversely impact wages, hours, and jobs for, in particular, low-income Americans?
Congressman, I've had some great meetings with Governor Pence and look forward to continuing those around Healthy Indiana and the expansion. I would say that, unfortunately, the Congressional Budget Office report, I think, has been mischaracterized. it does not say that the passage of this healthcare law will lead to 2 million fewer jobs. It does indicate that people will have some choices that they don't have today. They won't have job lock until they get to 65, where they have health care guarantees with Medicare. They can choose to stay at home. A lot of farm families will have the choice of not having to have an off-farm job to get health insurance for the family. So there is an average that they give, and they say you could have an average number of hours worked less, or they say you could have an average number of hours
I
worked
see our
more.
time has expired. I guess we could lower the definition of full-time employment to 20 hours, giving employees more flexibility under your analysis of the CBO report. But thanks so much for entertaining my questions. I yield back.
Mr. Kind is recognized.
Thank you, Mr. Chairman and Madam Secretary. Thanks for being here, and thanks again for your service to our nation. I know this hasn't been the easiest time, the rollout of the ACA. We didn't think it would be easy, but it's worth trying to do. First a comment and then a question for you. My comment, coming from a very large rural congressional district, just keep an eye on those critical access hospitals. They face some unique challenges as far as recruitment and retention and access issues, and I know we've had budget discussions about that in the past. The question is, one of the great stories in recent years, the last few years, has been the trajectory of healthcare spending, cost per beneficiary, which has never been lower in the last 50 years. I wonder if you could just take a moment to tell us what you're seeing in regards to the health system that's leading to these cost reductions. Obviously, part of the Affordable Care Act is to reform not only the way healthcare is being delivered, so it is more integrated and coordinated, patient-centered, but changing the financial incentives so it's more value and quality-driven. But if you could take a moment, just let us know what you're seeing as far as costs and whether these reports are sustainable in the future.
Well, Congressman, you and a number of the House delegation was instrumental in making sure that the sort of quality and value pieces were added to the Affordable Care Act, that became a fundamental piece of this. And I would say that the framework of having for the first time real tools within the Medicare system to look at aligning value with payment is significant. And we're already seeing the first real reduction in preventable hospital readmissions, a very dramatic change in hospital infection rates. Good for patients, good for the bottom line. In terms of overall expenditures, the 10 years before the Affordable Care Act, Medicare cost growth was on average 6% a year, year in and year out. Since the passage of the Act, 2010 to 2012, it was 1.6%, a dramatic drop. Last year, 0.7%. As you say, the lowest cost increases in history. And Medicare beneficiaries have more benefits, lower prescription drugs, additional costs. Private insurance costs have been cut in half during that same period of time. Overall, health expenditures in the United States per capita were raising at about 6% a year. They now are at 3% a year, again cut in half. And Medicaid expenditures, again, are seeing the lowest cost increases. But in part, it's because I think some of the fundamental structure of looking at ways to deliver more effective preventive care, earlier intervention with very high-cost patients, some of the pieces you put in place with the dual eligibles, a very expensive population, only about 10 million individuals, but people who spend over a third of both the Medicare and Medicaid budgets, that work with the states is very much underway. So there's some very promising trends, I think, on the horizon.
All right,
thank you.
Mr. Reed, and then we'll go to Mr. Blumenauer, and then we'll begin 2 to 1. Mr. Reed.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here today. I wanted to join with my colleague, Mr. Kine, to bring a message to you. Representing a rural district in western New York, I can tell you the Medicare and Medicaid reimbursement cuts that your proposals have done and implemented are seriously jeopardizing our critical access hospitals, our low-volume Medicare-dependent hospitals. I'm dealing with one right now, St. James Hospital, Lakeshore Hospital. Lakeshore is actually going through a closure. St. James is going through a rebuild. On the front line, in particular, on rural hospitals, these cuts are causing significant problems for access to care for our people. So I'm delivering to you some information and join my colleague in highlighting that need. Now, what I wanted to talk to you today about is we just had an election in Florida last night. The Democratic opponent was talking a lot about ways to fix the Affordable Care Act. And what I wanted to get from you is that the administration has had 37 significant changes in the Affordable Care Act that it has put forward by executive order and other amendments. And what I'm looking for you, if you have any suggestions, have you supplied to Congress, to us, in areas that you want to fix the Affordable Care Act? Has there been any legislation sent from the administration up to Congress in regards to those fixes?
I have not sent legislation to Congress, no, sir.
Yeah, because the answer is 0. I knew the answer to that question. I just wanted to see exactly where you were coming at. So why? So is the administration, the White House administration's position that the Affordable Care Act is not fixable, and therefore there's no need for any legislative fixes?
No, sir, I don't think that's the case.
So it is fixable. There's areas that you want to fix. Could you state for the record what areas of the Affordable Care Act does the administration want to work with us in order to fix?
Sir, we have said from the outset, from the passage of the law in March of 2010, if there are suggestions or ways that we can
So the White House has no suggestions or ideas on how to fix it.
We've implemented a number of changes in the way the law was written to ease the transition into the marketplace.
I appreciate that, because we've had the same thing up here on the Hill with the individual or the employer mandate delay, that we passed legislation, and then the White House vetoed that or threatened to veto it, and then by executive order implemented it.
No legislation has passed the Congress.
So if we pass that, you'll say you'll sign that?
I don't sign legislation.
Well, the White House. What's the White House's position on that?
The White House made their position clear, but no legislation has passed the Congress in the 3.5 years that the law has been implemented, and the House has voted 50 times to repeal the act.
Yeah, so when we pass a bill in the House and the White House issues a veto threat to it, that's an indication that the White House wants to work with us on policies that it's, by executive order, implementing. I mean, we have the employer mandate delay. You have the health insurance plan, that you can keep your health insurance plan if you like it. We get threats of veto from the White House on things that you're doing by executive order over there? Well, that doesn't make sense to us. Can you explain to the American people why that makes sense?
Sir, I think that the issue is the breadth of some of the legislation. We believe strongly that having a transition for people who are already insured gradually into ACA-compliant plans makes sense. The measure considered by the House of Representatives was considerably broader than that. It would have basically destroyed the new marketplaces, so that was a very different piece of legislation.
That's just not
All right,
true.
time has expired.
Thank you. With my time
Mr.
expired.
Blumenauer.
Thank you, Madam Secretary.
Thank you, Mr. Chairman. Madam Secretary, thank you again for being here. We appreciate your tenacity and your patience. I'd like to just shift something that doesn't bear directly on the Affordable Care Act. I worked very hard in that House version, and it passed this committee unanimously, provisions that would have provided reimbursement for voluntary consultation for patients who are facing difficult end-of-life circumstances. It stayed in the bill, but because of the reconciliation process, it dropped out. Since then, the evidence is even more compelling for the need for this service. I would just cite Reverend Billy Graham's most recent book, talking about the need for families to approach this, or former Majority Leader Bill Frist, in one of the op-eds on the Capitol Hill, pointed out that because of a lack of this planning and assistance, quote, patients are more likely to receive medical interventions that can actually prolong their suffering and will certainly increase the expense of their loved ones. Yesterday, I joined with the American Association of Clinical Oncology, who had just a great report about this and included a provision that I think is very compelling, that they have research that shows if you do this right, if you work with patients, you can actually, by adding palliative care, people will actually live up to 3 months longer while they get chemotherapy. Well, in November of 2010, CMS released a final payment rule that would have reimbursed Medicare doctors to have conversations with their patients on options for end-of-life care. This provision would have given people more control, and it speaks to much of the legislation, bipartisan legislation, co-sponsored by a number of people on this committee that Dr. Rowe and I have introduced. Yet, just days after that final rule went into effect, the administration reversed course, pulled it back, and it's been 4 years because of some sort of procedural something. Is there some way that we can work with you and our legislation so that we can give people, at no cost to the federal government, something that 92% of the American public thinks they want? Is there a way that this administration can work with this committee on a bipartisan basis to solve this problem?
Yes, Congressman, I would welcome that opportunity. I can tell you it's a personal passion of mine. My mother spent her last 10 weeks in 3 different hospitals with dozens of procedures, and basically I see it as being tortured to death. So I welcome the chance to look at how families and patients and providers can have more control over those end-of-life decisions. I also think that 2 things I would point out. One is that you did add to the Medicare benefits a wellness visit, a yearly wellness visit, which gives patients and doctors an opportunity to have conversations about health plans and potentially, have a conversation about issues that arise in critical care. But also, we are very much working underway with revisions in the hospice benefit area, and we hope
Very
soon
important.
to.
I see my time has expired, but I would hope after 4 years that you could revisit the rule, or that you support our bipartisan legislation so we can solve this.
All right.
Thank you very much.
Ms. Black and then Mr. Marchant. Ms. Black is recognized.
Thank you, Mr. Chairman, and Madam Secretary. Thank you for being here. I think that this dialogue is so important for us to have, because these are big issues that directly impact individuals in their lives. And so my first question for you is, do you believe that the individual mandate tax penalty is the central component of the implementation of Obamacare?
Congressman, I think that the mandate issue came from, I think, originally the Heritage Foundation and some other legislative analysis that ties it to getting rid of the pre-existing condition barrier for insurance companies.
So you do believe it's an important component?
You need to tie them together. Yes,
You
ma'am.
do believe. So I asked this question because in the Wall Street Journal editorial today, it was exposed that a rule released last week quietly excused millions of people from the requirement to purchase insurance or else pay a tax. And the rule actually allows Americans whose coverage was canceled to opt out of the mandate altogether. Now all you need to do, according to this, is fill out a form attesting that your plan was canceled and that you believe that your plan options available in the Obamacare mandates in your area are more expensive than what was canceled, and that you consider other available policies unaffordable. Further, there's also a provision that says people can also qualify for hardships for the unspecified non-reason, and I quote, "You experience another hardship in obtaining health insurance, which only requires documentation if possible." And yet another waiver is available to those who say they are merely unable to afford coverage regardless of their prior insurance. In a word, these shifting legal benchmarks offer an exemption to anyone who conceivably wants one. Keep in mind, though, that the White House actually argued at the Supreme Court that the individual mandate to buy insurance was indispensable to the law's success. So my question for you is, it just seems to me that only the people who might be subject to this individual tax are those who were never insured, because these are the people that were insured and then for whatever reason. Do you think that this is fair?
Well, Congresswoman, I did not read the Wall Street Journal editorial. I will read that later today, but I can tell you the description that you've just made is not accurate. The hardship exemption was part of the law from the outset. There were some very specific rationale there, and it starts with the notion that if you can't afford coverage, you are not obligated to provide, to buy coverage, and that has always been a framework. What this says is if your plan is unaffordable, you can file a hardship exemption. That was the part of the rule that was also
So if your plan
included.
is
It has always
unaffordable-
been based on affordability of coverage.
And if you feel your plan is unaffordable, you sign a form to say, attestation, my plans, I can't find a plan that's affordable for me. You just sign a document.
That has
saying
what,
that.
the hardship exemption has always been based on unaffordability of insurance. It has a measure in it.
So all of these
about income, that
exemptions-
if you're offered employer coverage,
Madam
but it's always
Secretary,
been in,
all of these provisions that came out in this rule that was sort of hidden, not very much exposed, you feel that was already in the law previously, and this is not a new piece?
what this allowed, the new piece is not the hardship exemption, which has always been part of the law.
Okay.
It allowed people who could not find an affordable option to also have the option of purchasing a catastrophic policy. That is the new piece, but it is not to get the exemption. The exemption has always been based on a hardship exemption.
I can
That's
tell you,
always
with
been part of the law.
37 different changes in this law, my folks are really confused about what this law does and doesn't do and what applies to them.
All right. Mr. Marchant.
Thank you, Mr. Chairman. Secretary Sebelius, I have been hearing from the seniors in my district who rely on Medicare Advantage plans to fund their health care. They are very concerned as they're seeing their benefit reductions increase and the result of the recent cuts to the program. It may come as a surprise to many seniors that only a small percentage of the cuts resulting from Obamacare have actually gone into effect. The vast majority of mandated Medicare Advantage cuts have not yet gone into effect and are backloaded in the Affordable Health Care Act. Can you please tell the seniors in my district that depend every day on their Medicare Advantage plans what to expect in the coming years once the Obamacare Medicare cuts are fully imposed?
Congressman, I think there's a very good story to tell on Medicare Advantage. Seniors are benefiting from what has happened since 2010 in a number of ways. The premiums in Medicare Advantage have fallen by 10% since 2010. The enrollment has increased to nearly 33%. It's increased 33% to nearly 30% of Medicare beneficiaries choosing Medicare Advantage plans. Quality has improved with our 5-star quality rating system, and taxpayers and other Medicare beneficiaries who were subsidizing the overpayment to insurance companies are now, again, seeing the benefits of that. So enrollment is higher, premiums are lower, quality is better. We have many more plan sponsors in the market. There is 99.6% of Medicare beneficiaries have Medicare Advantage choices, and I think we're seeing an even stronger program for the future.
The administration has issued countless waivers, modifications, and forms of release for business and others affected by Obamacare. 40% of the enrollees in Medicare Advantage earn less than $20,000 a year. Many of these individuals will have a significant problem in dealing with the premiums and in the cuts that they're experiencing in the future. Can you guarantee that they will receive the same level of benefits and the same access to their doctors? Because this is their biggest fear.
Well, sir, I can't guarantee the benefits that are outside of the Medicare benefit package. Insurance companies pick and choose. Some offer free gym memberships. Some offer free eyeglasses. I can't guarantee that. What I can say is that seniors have more choices than they've ever had. They have lower premiums in Medicare Advantage plans than they've ever had, and they have higher quality. More Medicare beneficiaries are choosing higher quality plans, and I think that's all very good news. Medicare Advantage plans are still being paid over 100% of the costs of fee-for-service, and that is what is gradually coming down, but there is no evidence. In 2010, it was stated unequivocally that these cuts in Medicare Advantage plans would destroy Medicare Advantage, that seniors would have no choice. That was just flat out wrong. And I think there is very good news for the seniors now who are choosing Medicare Advantage plans. They're paying less and having higher quality.
All right, thank you. Mr. Larson.
Thank you, Mr. Chairman. Thank you, Secretary Sebelius, for your dedication and hard work. We deeply appreciate it, and also your willingness to come before this committee and others and focus on what has been a frustrating rollout, but something that is vitally important to the American people, our economy, and most importantly, to the well-being of our citizens. You know, this is an issue that has been debated for the last 4 years. I was impressed with something that John McCain had to say, and I want to submit that for the record. But to summarize, in talking about the Finance Committee and what went on and the kind of debate that was taking place in the Senate and actually took place here on the floor, what Mr. McCain said, the Finance Committee submitted 564 amendments. 135 amendments were considered. 79 roll call votes were taken. 41 amendments were adopted. Then the Senate Health, Education, and Labor and Pension Committee approved the Affordable Care Act by a 13-10 vote. 500 amendments were considered. More than 160 Republican amendments were accepted. It's that kind of framework, even though Senator McCain disagreed and wanted to see the bill, didn't vote for the bill. What he said at the end of the day, and I think what the American people expect, is us to work together to improve the bill. What we see politically has been an attempt to totally repeal, to the far extreme saying every single letter of the bill ought to be repealed, including pre-existing conditions, including the great disparity that existed, especially for women as it relates to health care. There are a lot of positive, straightforward, pragmatic, programmatic reforms that have been made and are extraordinarily helpful to the American people. It is appalling to the American public. I come from a state where this is working extraordinarily well, where people are able to get insurance where they didn't have it before, where what was called the insurance capital of the world is now embracing and changing and meeting these reforms, where genomic projects and the biosciences are moving forward in an area that is going to be helpful. And the only thing that drags the country down is this endless, mindless debate instead of constructive criticism about how we can work together to improve the health and well-being of the American citizens. Thank you for your service.
Amen.
Thank you. Mr. Paulson.
Thank you, Mr. Chairman, and Madam Secretary, thanks for being here. You know, Americans needed real health care reform before the President signed the new health care law, and the fact is they still need it today. The more we learn about the President's new health care law, I think the more the facts show it's hurting more people than it's actually helping. I'm hearing from constituents on a fairly regular basis right now who are genuinely concerned. Many are upset, many are confused because of the different delays in parts of the law, and they're fearful. They're fearful about the cost to their pocketbooks for increased health care costs for themselves and their families. And instead of getting what the President, I think, promised when it was rolled out for having lower premiums and lower costs, many are now paying more for health care. Significantly higher deductibles, more expensive premiums. Many have lost their insurance, the plans that they liked or the plans that they had. Many have fewer choices now for doctors and for their plans, and there's no doubt that some companies have been forced to scale back hours with more part-time jobs and less full-time jobs. And so those employees that had good full-time jobs now have part-time jobs. And there are jobs that are being lost. I know the medical device tax was a central component for the revenue stream of the Affordable Care Act, but we got 33,000 jobs now that have been estimated to have been lost in this industry. And this is one of our best American success stories. This is where health innovations come from to help patients. And I've got 51,000 seniors in my district that are part of that Medicare Advantage population. And some of the past cuts in the MA program and some of the proposed cuts are certainly giving them concern for losing benefits or maybe even losing some of their plans. And I think, Madam Secretary, the irony in all this is that in Minnesota, a state like Minnesota, where we had one of the lowest uninsured rates before the law was put into place, we're actually likely to see an increase in the uninsured number now because the law eliminated a lot of the reforms successfully that had been implemented in a state like Minnesota. So my question, Madam Secretary, is why should the administration, as a part of your budget request, get another $1.8 billion for the exchanges, for all the other programs that are associated with the rollout of Obamacare?
Well, again, Congressman, I think that the evidence out with the recent health survey in the last 2 days indicates that the overall uninsured rate in this country is actually going down. So more people have insurance coverage, according to the survey, than did before this law was passed. So the evidence says that this actually is making an impact, and a positive impact. I would also say that the vast majority of Americans have coverage through their workplaces, and that coverage over the last 3 years has gotten stronger. There are more consumer protections, so they can't be they don't have an annual cap anymore, and they can't run out of treatment during chemotherapy. They have some features that they didn't have before, but that's in place. Medicare has gotten stronger with this plan. There are additional people who now have Medicaid benefits, and the
I don't mean to
individual
interrupt,
market.
Can I just ask one more question? Do you expect health care premiums to increase again next year on average? Will they go up? Because they certainly went up for a lot of folks this year, but do you expect that trend to continue next year again?
I think premiums are likely to go up, but go up at a smaller pace. And what we've seen since 2010, the increases are far less significant than they were prior to the passage of the Affordable Care Act. Yes, sir.
All right, Ms. Jenkins.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here. Greetings from Kansas.
Thank you.
I wanted to visit with you about the President's health care law and the costs associated with it. The American taxpayer, it's been estimated, will be billed nearly $2 trillion over the budget window, and the costs continue to mount. A Government Accountability Office, GAO, report issued last year says that the law will increase the federal deficit $6.2 trillion in the long run. The cost of this law seems to be rising every time we turn around. In the budget proposal that you're here to discuss with us today, the President's requesting another nearly $2 trillion for the health care exchanges. And after all the broken promises, like if you like what you have, you can keep it. If you like your doctor, you can keep it. Premiums will go down by $2,500. I'm wondering if you can tell us all today what happened to the President's promise. And I'll quote him. He says, "I will not sign a plan that adds one dime to our deficits, either now or in the future." This is what he told us in a joint session of Congress in September of 2009. "I will not sign it if it adds one dime to the deficit now or in the future, period." So given that the President's budget that you're here to defend today never ever balances, can't ever point to a time in this nation's future that you will stop spending more money than we take in, I'm just wondering how you can explain his promise to us, first off.
Well, Congresswoman, greetings back to Kansas. And the Congressional Budget Office, which I think you all rely on for scoring various pieces of legislation, when the Affordable Care Act was passed, said that the passage of the act would save about $100 billion in the first year, the first 10 years, and then closer to $1.1 trillion in the second decade. They updated that score and made it even more generous when cost trends began coming down. That is what the Congressional Budget Office said. They have scored that again. Every time there's a vote on repeal and questions are asked, they continue to say repealing the Affordable Care Act would actually add to the deficit, not that it would subtract from the deficit. So that, I think, is exactly what the President was talking about when he said he wouldn't sign a bill. Unlike the Medicare Part D, which was paid for on some credit card and added enormously to the deficit and still was never paid for, The Affordable Care Act was fully paid for within the scope of the law and was
But,
scored
Madam
as
Secretary, it's not
detracting
fully-
from the deficit.
It's
So
not fully paid for. How can you explain, and now that you have the data that indicates this will add over $6 trillion to our national debt, what have you proposed that's going to bring that into line?
I have to tell you, Congresswoman, I'd be happy to try and answer that. I have no idea what the $6 trillion to the national debt is based on, so I'd love to.
But you do know what the Government Accountability Office is, and are you questioning their...
I've never seen the study that you're talking about. Yes, I
All right.
do know what the Government Accountability Office is. Thank you, but I'll be happy to look up the study. I'm not aware of that. I do know the scoring on the Affordable Care Act by the Congressional Budget Office, and it continues to be updated, and I'd be happy to provide that to you.
All right. Mr. Thompson.
Thank you, Mr. Chairman. Madam Secretary, thank you very much for being here and for your tireless effort to ensure that people have access to quality, affordable health care. I'd like to ask you questions about two things that are in the budget, and I'll just ask the question and give you time to respond. One's the new GME program. I think this is an issue. Ms. McMorris Rogers and I have a bill that would hopefully provide more opportunity to train physicians. And as you know, folks tend to practice where they train. And in areas, especially rural and underserved areas, this is huge. The administration has a targeted support program. And I'm just interested in what sort of assurance we'll have that they'll provide training outside of hospitals and in community-based settings, and what the certainty is going to be in this program. As you know, the residency programs take a long time, and I want to make sure that the program's in place so folks have a certainty. And then secondly, on the administrative law judge appeals funding, the administration has put $100 million in for Medicare hearings and appeals, and I know that's a little more than was in last year, but I question whether or not it's enough. And what are you going to do until the proper funding level is reached to make sure that our constituents don't get hung up in this void?
Congressman, the training grants will be consistent with the workforce goals, which include targeting more physicians to primary care and understaffed specialties, encouraging the practice in rural and underserved areas, and encouraging training in some of the key competencies for delivery system reform. So I think it's very consistent with the outline that you have made about your goals in workforce, and I think the HRSA, the Health Resources Services Administration, who would be administering these training dollars, have the expertise in identifying the underserved areas throughout the country in the whole workforce capacity issue, and that's why I think this program is really on target to try and not only train the providers that we're missing, but making sure connecting them to the areas that are the most underserved. In terms of, what was your second? Oh, yes, the administrative appeals. We're doing two things simultaneously, and we would welcome the opportunity to work with Congress. We don't want to recede from what are appropriate examinations of overcoding and overbilling and fraudulent activities. On the other hand, I think there's some system changes we can put in place, but we share your concern that beneficiaries should not be in some queue waiting for appeals to be made, and we're trying to triage the system, but we would love to work with you on it.
All right. Thank you. Mr. Smith.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for taking time to have a conversation with us here today. Obviously, the issues are very important. I'm concerned that some of the policies enacted out of Washington, D.C. are actually hurting the very people, individuals they were intending to help. If you could elaborate or reflect a bit on critical access hospitals, we know that that is a singular designation for a number of different approaches in various parts of the country, and obviously I represent a large number of critical access hospitals in rural Nebraska. I'm sure you're probably familiar with facilities in Kansas.
the treatment of these hospitals with kind of a cookie-cutter, one-size-fits-all approach, whether it's the 96-hour rule, whether it's the physician supervision. And these are very cumbersome and burdensome. I've tried to find out exactly how and why they were adopted or proposed even from HHS and CMS. Have those saved money? I mean, can you point to the effectiveness of these things? Because it seems to me that the very professionals who are trained to make healthcare decisions find Washington, D.C. meddling and standing between a patient and their provider.
Congressman, I certainly share your concern about the important nature of critical access hospitals, and as you say, coming from a state of Kansas where a vast territory is rural, and closing a hospital often means closing a community. I know how essential a hospital presence is. I think that what the administrators at CMS are trying to do is find the appropriate balance. As you know, critical access hospitals are still paid more than 100% of Medicare reimbursement. There is some evidence that the proximity of one hospital to another kind of belies the definition of critical access.
To these arbitrary regulations, say physician supervision, for example, requiring a physician to be on the premises, on the same floor of the premises, when a phlebotomist might draw blood in order to be reimbursed. It seems to me that would actually drive up the cost of the delivery of care rather than, find an efficiency.
Well, again, I'd be happy to take the specifics back and try to find the evidence behind why specific recommendations were made. I can assure you that at least the staff that is looking at these situations is very concerned that patients not be jeopardized by the care and trying to not add administrative burden. But I would be happy to, if you can give me some specifics
Absolutely.
And get the evidence back to you.
Thank you. And again, I think these are examples that I hope we can avoid of the federal government standing between a patient and his or her provider. Thank you. I yield back.
Thank you. Mr. Buchanan.
Madam Secretary, thanks for being here today. I want to touch on the biggest issue in our area, employer mandates. A lot of people are concerned. I'm looking at a New York Times article. It's about 2 weeks old. I'll be glad to give it to you. But it says cities, counties, public schools, community colleges around the country are being limited or reducing hours in terms of part-time employees to avoid paying health care insurance under the ACA. And this is coming from state and national leaders from around the country. Are you aware of this, and do you have any sense of the impact that this is having on communities? And I can tell you in our community in Sarasota, Bradenton, Florida, it's a gigantic issue.
I have heard, Congressman, certainly conversations about the 30-hour kind of cliff that more than 30 people would be required to provide health coverage for those employees. Less than 30, they would not. Again, I think there's disputing evidence of what's happening with that, but we're watching it very closely.
I would just ask you to take a look at it. We need to clearly, because this is, I know we're trying to get more health care out there, but everybody's taking, in a sense, a 25% pay cut. I also want to mention something you said earlier about the fact that it only affects 2% of the businesses. Do you have any idea? It's one way to spin it or present it, but do you have any idea what the 2% make up in terms of the number of jobs that they impact in the country? Do you have any sense of what that 2%? And I'll say that because I've got one employer in my area. They have over 1,000 employees. They're moving most of their employees from 40 hours to 29, and they're part of the 2%. But I think you're looking at 20–30% of the jobs across the country are going to be impacted by these mandates. And even though you're pushing the mandates off, people are making those adjustments in the public sector and the private sector today. So we're very concerned about that, but I'd like to have you get back to me on what that 2% makes up. One other thing I want to just mention on terms of taxes and revenues, part of the reason we're having a record surplus this year, not a surplus, but a record revenues this year, because we did increase taxes through 25%. We went from 35 to 44. That's what the pass-through entities are paying that create a lot of the jobs in the country. And if you look at the taxes for state and federal, The average across the country is 49.6. So I don't know how much more burden we can put on our employers across the country. As you mentioned, we need additional revenues. I hope you're not considering going after more pass-through entities that are the job creators of America.
Congressman, one thing I would point out is that the recently released rules by the Treasury Department did look at the 30-hour employee, and particularly the kind of mixed work group where part-time and full-time, and indicated that employers, if they offer coverage to 70% of their employees, would meet the criteria. I would tell you that the 30-hour definition came out of the offerings in the private sector marketplace prior to the Affordable Care Act. That's what employers chose to do, that people who were making or working more than 30 hours were defined as full-time employees, people who were working less. So as the Congress looked across the country, that's where that hour rate came from. But we are watching, as I say, that very closely.
All right. Thank you. Mr. Doggett.
Thank you, Mr. Chairman. Madam Secretary, so much of the original promise of the Affordable Health Care Act has been undermined by faulty implementation that has sometimes been indifferent to local concerns. Last month, the Congressional Budget Office, as you know, concluded that faulty implementation of the health care law, quote, impeded so many people's enrollment in exchanges that 1 million fewer people will actually obtain exchange coverage this year than they previously projected. From your testimony this morning, it's clear we will not have 7 million or even 6 million. And of course, the number that's really important is not how many people have enrolled, but how many people have paid their premiums and are actually getting an exchange-based coverage, a number we've never been given. As you're aware, since last August, I've been voicing concerns to your office about implementation in Texas. At best, less than 10% of exchange-eligible Texans have selected a plan. In other words, more than 90% of the people whom we wrote this law to get exchange coverage have not been covered. It would, to meet your projections, we would need to enroll and have premiums paid for as many people this month as have been enrolled since the beginning in October to yesterday, or last week. This is much more than a website problem, though I believe that the individual assistance program there has been handled with about the efficacy of the original website rollout. I've been unable to get straight answers about even who is responsible for coordinating in-person assistance in Texas, a place where we have multiple assisters in some areas and none in many others. I have sought to get even just a dedicated line so that the certified counselor who yesterday had put in 10 hours trying to help one person would be able to call a line dedicated to assistance counselors to be able to get prompt assistance and help people get enrolled in this. But there's been no response from HHS or CMS about that. It seems to me that we're to a point where instead of just circling the wagons against all the political arrows that are shot against this plan, we need a little more accountability, and we need to ensure that the next enrollment period is not handled as poorly as the last one. I'm very interested in answers to the questions that the chairman raised at the beginning of this hearing. We haven't gotten them yet, and I hope that we do get them. We come at this from a different perspective, but taxpayers deserve to get their money's worth. And I think much of the focus as it relates to in-person assistance needs to be to find out, and I assume, Mr. Chairman, that some of these questions I've been raising since last fall can be submitted by you with your questions for prompt answers, such as how much it cost us per person who's actually insured through the exchange for some of these contractors that have been providing these services. 2 Washington Beltway contractors have been paid $9 million for in-person assistance in Texas. I've been unable to find out what it costs per enrollee for those persons. And so I think that while our goal should be to try to improve and strengthen this act, if it is to perform any better in the next enrollment period than it has in this one, we need answers to these questions to get the taxpayer their money's worth and to get the promise of this act fulfilled. And I yield back.
All right. At this time, Dr. Price.
Thank you, Mr. Chairman. Welcome, Madam Secretary, back to the committee. I think you sense a growing lack of trust that we reflect from our constituents. Americans have a growing lack of trust in their own federal government. I think there's no doubt about that, and I would suggest that Obamacare is really the poster child for one of the reasons that exists or that's increasing. And it's because word isn't matching deed. Promises have been made and absolutely broken. And as a former practicing physician, it's distressing because we're not talking about just some nebulous program. Now we're talking about real people's lives. And in so many ways, some of the stories that you've heard here, real people are getting harmed. In spite of that, you have the Senate Majority Leader, Harry Reid, taking to the floor of the Senate and saying any story that decries a problem with Obamacare, all of them are lies. Do you agree that all of these stories that have been read are lies?
Congressman, I did not hear what Senator Reid said, and of course there are lots of anecdotes of lots of people and lots of success stories.
If you were to have heard the Senate Majority Leader say all the stories about ACA
I
are
really
lies.
don't want to comment on his comments. I didn't hear them.
Again, and that's the kind of trust that's lacking because it begs.
I just said clearly there are lots of people and lots of real stories. I don't assume that people are lying.
Questions. You mentioned in your opening remarks 4.2 million people have signed up on the exchange, and I want to get to some of the concerns that others have. How many of those that have signed up, that have enrolled in Obamacare, have paid their premium?
I can't tell you that, sir, because I don't know that.
How can it be that HHS, in charge of this program, cites a number, 4.2 million people signed up, but has no idea how many people have paid?
Because the consumers don't pay us. They pay their insurance company. We can tell you who has enrolled. We get information now in aggregate form of the customers who qualify for a tax credit. Not all their customers do.
How many of those, of the 4.2, were previously insured?
I do not know that, sir.
Isn't it true that many members of Congress are in that 4.2 million? We had insurance before. We were forced off that.
I assume if you have signed up on the exchange, you are in that number. Yes, sir.
And, McKinsey did a recent survey that said 27% of those joining the exchanges were previously uninsured, and that's a low number compared to what you all projected. Is that consistent with your information?
Again, we don't collect the previously insured. I think these questions would be, we'd be happy to give them to you as soon as we have accurate information. In the meantime, insurers have this information about their customers because that's who's being paid and that's who's enrolling.
It begs credulity, Madam Secretary, that you don't know the answers to these.
These are private insurance plans, and customers
you all are
buying
charged with
a
running
private
the
product
program.
from a private insurance plan. We qualify them. We get their tax information to make sure they qualify, and then send them to their company.
The American
and they
people
enroll
trust
with
that
the
you
company.
know what you're doing and you're not filling the bill.
This is not Medicare or Medicaid, sir. It is a private plan in the private market. It is not government insurance, in spite of the fact that it's been characterized that way. People are buying a product in the private market. As soon as we have accurate information, we will give it to you, but we do not currently have information about how many people have paid.
Sounds like last fall, Mr. Chairman.
All right. Mr. Gerlach.
Thank you, Mr. Chairman. Madam Secretary, there is a section in the ACA on a reinsurance tax. Is that correct?
Yes.
What's the purpose of that reinsurance tax, the proceeds from that tax?
Well, there actually are three components of risk corridors, reinsurance tax, and risk adjustment. A 3-year program that, again, is paid for by the insurance companies operating in the market. And it's to really balance the risk pool. It's exactly the same as the risk program in Part D when Part D started.
I'm focused on the reinsurance tax in particular. Are the revenues to be used to fund other portions of the Act, including exchanges?
The revenues will be used to balance the marketplace.
How much is expected to be raised in the reinsurance tax this year?
This year? Yeah. 10 billion this year. I was just told the figure is $10 billion for this year.
Okay. But there's also a proposal out there to provide waivers to some of those that are right now under law to pay that reinsurance tax. Is that correct? In particular, unions?
Oh.
If they're self-administered and self-funded.
Yes. This is the, I'm sorry, the rule that if you are self-administered and a self-funded plan, you do not pay the tax, and that is not exclusive to unions. There are a lot of self-administered, self-funded plans
Okay,
that
so
are not paying the tax.
how much relief under this waiver will unions receive as a result of this rule?
I could get you that information.
Can you give me a ballpark right now?
I can't.
Okay. Well, I find it curious that the reinsurance tax section of ACA is very clear as to who is to pay that tax. It's to be used then to help fund aspects of the ACA, including exchanges, and yet the President's requesting an additional $1.8 billion in his budget request for program management to continue to build and operate exchanges. So what it seems to me is you're providing a waiver to perhaps what would be termed political friends, not to pay what the law requires them to pay, but then coming back to the taxpayers and asking them for more money to help fund the exchanges.
Well, sir, the statutory language talks about issuers or those who operate plans with third-party administrators. And the self-funded, self-administered plans, which are a much broader category than you've just described, are not in the statutory configuration of the law. In addition, the 1.8...
Okay, just so I'm clear what you're saying, Madam Secretary, just make sure I understand what you're saying. It's your determination that those that are being granted this waiver are not covered by the language of the Act, and therefore you're granting
They're not an
that waiver.
issuer, or do they operate with a third-party administrator? Yes. Self-funded, self-administered plans, again, much broader than the category of unions. There are many who operate that way, are not specified in the statutory language.
Then why were the unions jumping up and down asking for this relief if they weren't covered by the tax to begin with? I
can just tell you that's what the statutory language says. That was our interpretation of the statutory language. That's the rule we put out. The $1.8 billion that you suggest, 1.2 of that will be paid for by user fees. $600 million is the request for appropriation.
All right. Mr. Becerra.
Thank you.
Thank you, Mr. Chairman. Madam Secretary, great to have you with us. Actually, before I go to some of the questions about the Affordable Care Act, I wanted to check in with you regarding the financial alignment demonstration project being carried out in California called the Dual Eligible Program for beneficiaries who receive both Medicare and Medicaid. We share the goal of ensuring that everyone who transitions into this program will have uninterrupted quality health care that they can count on. And I was just wondering, will you and CMS Administrator Tavener keep us informed as you continue the rollout so we can make sure that there's a successful implementation of that program?
Yes, sir, we will.
Appreciate that. Now, I know that even today, if anyone's watching, there's no reason why folks should not be left with some sense of misunderstanding about what's going on. The disinformation and scare tactics that have been used over and over again have been difficult to combat. But I wanted to just make sure about something. As I read the facts, since the passage of the Affordable Care Act, you mentioned that several million people have now become insured. In fact, I think you mentioned that over 4 million people now have private health insurance. Did you mention the 3 or so million young Americans who have insurance as a result of the Affordable Care Act? Now they can stay on their parents' insurance policy?
I did not mention that.
But that is about over 3 million or so?
Yes, sir.
And we have some
3 million previously uninsured. Far more young adults are on their parents' plan, but 3 million previously uninsured young adults.
Got it. And we have some 4 million or more individuals who now are on, who now have health coverage as a result of Medicaid.
Closer to 8.9 million in the Medicaid. Some of those are renewals, some of them are newly eligible in states that chose to expand their Medicaid program.
Right, so the 8 million plus number includes people who probably qualified before but had, or who just transitioned from current Medicaid, what they had before, to what they have now.
Some states require yearly renewals, and they are included in that, but there are close to 9 million people who will have Medicaid coverage. A number of those are newly insured.
So if I do the quick math, 9 million under Medicaid, 4 million with the private insurance under the marketplace, 3 million young adults, that's about 16 million Americans who have health security today that they might not have had before.
That's accurate.
My understanding as well, looking at the job numbers, that since the Affordable Care Act passed, more than 8 million jobs have been created in this country, not lost. And in fact, if you look just at I looked at just the healthcare sector, and in the healthcare sector, since the passage of the Affordable Care Act, we've seen over 1 million jobs created just in the healthcare sector. So as we continue to hear folks talk about job loss, that the Affordable Care Act will result in job loss, just the opposite is occurring. And of course, we're also finding that we've seen a decrease in the rate of increase of the cost of healthcare, which I would think you'd agree is a good sign.
I think that is a good sign, and in the job front, we also see that the number of people working part-time hours is decreasing, the number of full-time workers is increasing.
Mr. Chairman, if I could just add to the record, ask unanimous consent to submit into the record the CBO's updated estimates that deal with job loss and the issues of employment and job creation.
Yeah, without objection. Mr. Roscom.
Thank you, Mr. Chairman, Madam Secretary. We just heard from Mr. Becerra, who criticized critics on and characterizing it as misinformation or disinformation and scare tactics, and yet that wasn't what we heard from Mr. Doggett. Mr. Doggett was essentially admonishing the department for a lack of information and a lack of accountability. So I want to associate myself with the spirit of Mr. Doggett and also bring in one of the themes that Dr. Price was trying to articulate, and that's this. Wouldn't it be great, Madam Secretary, if Dr. Price, in the question that he asked, you were able to say, here's the answer. Here is the answer. When he made the inquiry and you said, you know what, I don't have that information. I'm just the Secretary of Health and Human Services. That is with the private insurance company. That was your answer a minute ago. Wouldn't it be a great thing if you were to say, here's the information and here's the answer? And the problem is, at least as far as the construction of the Affordable Care Act, as it's currently constructed, some of this information you may not know, some of it you may, but it's because of limitations of the Act itself. So we've got an Inspector General, and your own Inspector General is only able, Madam Secretary, to go and ask inquiries of Health and Human Services. That Inspector General, who reports to you, cannot go and make any inquiries to Treasury. One of your earlier answers, you cited tax credits. Well, when it comes down to it, the HHS Secretary has no jurisdiction over tax credits. You don't know what's happening in that other department. Wouldn't it be a good thing if we were to amend the law and you had that information, and there were a special Inspector General that had broad jurisdiction? Wouldn't that be a good thing?
I don't think that's necessary, and I think that's additional expenditure. I will give you the information as soon as we have it, and we will have it from insurance
but by your own
companies,
admission,
but
you
we
don't
do not
know
have it now.
So why is it a good idea to have a special Inspector General for Iraq reconstruction? Why is it a good idea to have a special Inspector General for Afghanistan reconstruction? Why is it a good idea to have a special Inspector General for TARP oversight? Cumulatively, all of these have literally saved billions of dollars. The Affordable Care Act, according to the Congressional Budget Office, is a $1.8 trillion expenditure. What is it that is sacrosanct that says that this should not be subject to that broad jurisdiction? By your own admission, you don't know the answers to these questions, do you?
I could not answer Dr. Price's question because I don't have the information from the insurance companies yet.
Right, because
we will
you
have
can't
it, and I
reach
will.
out.
This is in the private sector. This is not Treasury. This is private insurance companies.
That even begs the
300
question.
of whom are
You
selling
can't get to
policies
it.
in the marketplace.
Your Inspector General can't get to it.
This is not an Inspector General issue. It's private insurers who are selling plans to their customers. They can tell
That's
you
even
how many
worse.
of their customers
It's
have paid their
ongoing,
bills.
and you don't have
right.
the information, and you don't have the capacity to information.
I would just say, Madam Secretary, part of the frustration is that you did have the answer to the number of insured children, and that is also private sector information, but yet when we're trying to get further information, we don't seem
That
to be
came
able to get it.
directly, Mr. Chairman, from the insurers. And I'm telling you, as soon as we have this information from the insurer, we don't collect it, we didn't have it, they turned that in to us.
All right. Dr. Bustani.
Thank you, Mr. Chairman. Madam Secretary, one of the glaring omissions in ACA was addressing the flawed physician payment formula under Medicare, SGR, the Sustainable Growth Rate formula. A lot of work's been done. It's been a thorny problem facing Congress for quite a while. And over the past few years, we've actually gotten to an agreement on the policy. Bicameral, bipartisan. So first question, does the administration agree with this policy, and will the administration support this policy?
Well, as you know, Congressman, the President has supported a long-term fix of the SGR long before the Affordable Care Act was signed into law. He's included it in every budget, and yes, we do support the bicameral position.
Okay. The other issue is going to be paying for this, and this will be a difficult fight, obviously, and it certainly can become a partisan fight. But in the interest of trying to get something done, will the administration come forward and work with Congress, work with the Senate to try to get to a solution on this?
We would be eager to do that. The first couple of budgets that the President put forward had specific pay-fors. Those were rejected. He does assume that the SGR is fixed. We've put that in our baseline for the next 10 years. We would be happy to work with Congress.
And pursuant to that same question, the President in the past put on the table some Medicare reforms that would help, I think, improve the outlook of Medicare over the long haul, one being combining Medicare Part A and Part B into a single structure, making it work more like a modern insurance-type program. A second was limited means testing. Does the President still support these?
I think, as you know, Congressman, that was put on the table as part of a global package of both entitlement and structural spending reforms, and we would be eager to talk about those issues in that kind of global package.
But not within the context of reforming SGR, which is a pretty big piece.
Well, the SGR does impact certainly Medicare physicians. It's probably the single biggest threat to Medicare's future in terms of beneficiary service, the looming
It's a threat to access.
So we are eager to talk about pay-fors, but I think having a more global discussion about entitlement reform, tax reform, and revenues is also something we'd be eager to.
And finally, is the administration willing to put forth the capital to try to solve this before the end of March so that we can avoid another patch, which will be expensive?
Put forward the capital. Again, we'd be happy to have the discussion with members of Congress about what the pay-fors might look like.
Thank you, Mr. Chairman.
Thank you. Mr. Neal.
Thank you, Mr. Chairman. Madam Secretary, I'm going to come back to your role in a few moments about as a trustee of Medicare and Social Security. But just a reminder here that the Democratic minority vigorously opposed the original Part D prescription drug benefit plan offered by the Bush administration because we did not think it had gone far enough. Upon ascending to the majority right after, we took the role that not to undo what had been done, but instead to work hard to improve it. And closing the donut hole was a pretty masterful piece of work. And now there's broad acceptance of the whole notion of the Part D benefit. Now, I would wish that that would have been the model that we would have adopted in Congress for working with ACA. But let me draw your attention specifically to a couple of issues. Graduate medical education and the role of Medicare in financing our hospitals across the country. As you know, in Massachusetts, our hospitals would be the equivalent of what Boeing perhaps means to the Pacific Northwest. I think that's a reasonable description in terms of not only the success that they have, but the employment opportunities that they present. You, I think, by law, have to sign every year a document certifying as to the longevity of Medicare. Is that correct?
Yes, sir.
Would you talk a little bit about what ACA has done to that signing?
Yes, the first year I was a Medicare trustee in 2009, the anticipation was, the actuarial projection was that Medicare would begin to be insolvent, not that they wouldn't have any money, but they'd have about 70 cents on the dollar by 2017. So in 2009, it was a 2017 cliff. The passage of the ACA added years to that solvency, according to the actuary who looked at the law and the impact over time. And subsequent budgets have also added years. So we are now, the 2015 budget, according to the actuarial projection, would add an additional 5 years to the solvency of the Medicare Trust Fund. So during this administration, I would say significant solvency years have been added.
Are there Republican trustees?
Yes.
Do they sign the document?
Yes, they do.
And did they sign?
Yes.
Okay. My point is that here's an example, again, of a very good story, much like the one that Secretary Lew presented about deficits in his appearance before the committee recently. And it's frequently underreported in terms of the good news because the emphasis remains on the conflict of the story as opposed to the substance of the story. So I would hope that you use the opportunity with Medicare solvency, graduate medical education, to promote the notion that this is a widespread success story on that basis.
Thank you.
All right. Thank you. Mr. Reichert.
Thank you, Mr. Chairman. Madam Secretary, you, in response to Mr. Reed's question regarding legislation, your answer was that there was no legislation that has passed Congress. There's no legislation that has passed Congress. Are you aware that there are actually 8 pieces of legislation that have passed Congress and been signed by the President in regard to the Affordable Care Act? There are 8 pieces of legislation passed by Congress and actually signed into law by the President. So there's another, I think you ought to go back and review the laws that have been passed that affect the law that you're trying to implement. I want to go back real quick. It's been 4 years since passage of the health care law, nearly 6 months since the exchanges opened for business. So let's look back at the 4 years. In January 2010, the President spoke at the White House Republican retreat and acknowledged that some stray cats and dogs were added to the health care bill and that some of the provisions that got snuck in the law might have violated the pledge that if you like your health care, you can keep it. If you like your doctor, you might be able to keep your doctor. In February 2011, during your testimony and my questioning, you said, in response to whether or not you can keep your doctor or your health care, you said, I don't think there is any language in the bill that interferes with the current system. Again, you were wrong. Again, in February 2012, when I raised these same concerns, you said, oh, the notion, quote, the notion that somehow companies in grandfathered plans will not be able to keep their grandfathered plan is really not accurate, end quote. Again, you were wrong. Yet, due to the law's many mandates and the regulations put out by HHS, under your leadership, as many as 5 million Americans have lost their existing health care plans. The law has created so many disruptions that the President announced, perhaps illegally, we think, that states and insurers can begin to ignore the law. In fact, as Mr. Reed said, there are 37 changes to the law. September 24th, September 26th, October 23rd, November 14th, there were 7 more changes to the law. On November 22nd, November 21st, 22nd, January 1, November 27th, and 30th of November, December 12th, December 19th, December 23rd, and then, Secretary Sebelius, you were on Fox News and assured of, the American people who were watching Fox News at that time that there would be no more delays. Yet, on January 10th of this year, another delay. January 14th, another delay. And then February 10th, another delay. Are there any further delays? Can you make a promise to the American people today, another promise, Madam Secretary, that there will be no more delays to the so-called Affordable Health Care Act?
We will continue to put out regulations
Can you make
and
a promise
policies
to the
as
American
we go through this act. And, sir, I'd like an opportunity to correct some of the I think, misstatements.
Will
There
there-
is
will there be
nothing in the
further
law
delays?
that would stop insurance
Will there be further
companies from-
delays, Madam Secretary?
There are no planned delays in the law.
You
no.
consult with HHS when you, or, pardon me, do you consult with the Treasury Department before announcing any delays and changes?
Sir, that most of the
consult with the Department
regulations
of
that
Treasury?
most of the regulations
Do
that
you
are
consult
written
with
are
the
written
Department of
with.
Treasury, yes or no?
Sir, the regulations require 3 agencies' participation: Treasury, Labor, and HHS, so there's broad consultation.
Okay, thank you.
Is recognized. Thank you. I'll just quickly say to my friend from Massachusetts, he should look at the unprecedented original appendix, the trustees report that talks about the double counting that occurred, and the putting Part D on the credit card. The Democratic proposal was more than double the credit card bill. Here's what I want to ask, Madam Secretary. We keep this list here in the budget, in the Ways and Means Committee about all the delays. We got 23 so far. One I want to ask you about is IPAB, the Independent Payment Advisory Board. In your table S9 of your budget, last year, you claim in your budget you're going to save $4 billion from IPAB's recommendations. This year, you tripled that to $12.9 billion for IPAB's recommendations. This is above and beyond all the provider cuts that are in the ACA to pay for the ACA. So here's my question. Where are we with IPAB? They have given us their last April report. I assume another one's forthcoming from the actuary. But where's IPAB itself? When are you going to submit the names? If you don't do that, as you know, the law lets you, one person, submit the plan to save the $12.9 billion. So what's happening with that? And if you're going to do it, how do you come up with the $12.9 billion? Where is that savings coming from?
Well, Congressman, the President has not yet sent to Congress names for the nominees of IPAB. But as you may know, the law is constructed in a way that IPAB wouldn't trigger any recommendations unless there is a gap between what the trajectory.
I realize that, and you're
cost-
claiming $12.9
so
billion.
They would not have any recommendations to make in the foreseeable future.
So-
Nor would I take any action in the foreseeable future
Okay,
as long
so
as the
how?
cost trajectory is
So
where it
are we
is.
to ignore the fact that you're claiming $12.9 billion in savings from IPAB?
I think the President intends to submit names to Congress as we watch the cost trajectory, if the cost trajectory changes, and IPAB will be in full effect, and those recommendations are presented to Congress, as you know, not to me. They come to Congress.
No, I realize
And if
that.
Congress doesn't change them, then they go into effect.
Or you just recommend them if there is no IPAB at the time?
If there is no IPAB, that's correct.
So you have no answer to where the 12.9 is going to come from?
We are optimistic that the current trajectory of Medicare costs would actually negate any impact of IPAB or me taking any kind of action in the foreseeable future.
That's another way of saying ignore our budget because it's not real.
I think the IPAB recommendations are based on an actuarial
No, I
projection
understand.
of out
You go from
year
GDP
costs,
1
but
to
so far
GDP
they-
5. I get all that. You did that last year. You went to GDP 0.5 last year, and you still had $4 billion. Now you triple your savings to 12. And the question is, where is it coming from? What are those justifications? What's the assumption you're using to claim this savings to show how your budget is put together?
I think the actuarial projection is that out-year Medicare costs will rise again. So far, they have been incorrect about those increases. We are hoping that they continue to be incorrect. And so if the IPAB indeed does rise, the trajectory rises, IPAB would kick into gear, and we will make recommendations through the IPAB to Congress about those specifics.
So you're saying, though, just so you know, in your own budget, it's going to triple from this year to last year. That's coming. It's above projection. You've got it in your budget, but you're telling me you have no idea where where in Medicare you're going to cut to get that, is basically what you're saying.
It's based, again, on what the actuary,
I
the
understand
independent
that.
actuary says will happen in out years. Currently, we have not made specific recommendations about any cost cuts because none of that is actually happening
Okay,
right now.
I know time's out. When are we going to see the names? When are we going to
I
see
can't
iPad?
tell you, they come from the president. I don't
All right.
know when you'll see
Mr.
them.
Davis.
Madam Secretary, thank you very much for being here. But also I want to thank you for the Medicaid waiver for Cook County in the state of Illinois. As a result of that action, the governor's expansion of Medicaid, and a lot of hard work on the part of a lot of people, Illinois is doing much better in sign-ups for the Affordable Care Act than many other states. And for that, we are indeed grateful. I'm a big fan of home visiting programs and community health centers, and I'm pleased to note that both are included in the budget. As a matter of fact, I get my personal care at one of these centers in Chicago at the Mile Square. Could you elaborate on the value and effectiveness of these two programs that relates to providing health care for especially low-income people?
Well, Congressman, I share your high regard for both programs. I think that there's no question the community health centers are the backbone of primary care delivery in this country, in rural and urban areas. They are proven time in and time again to deliver lower cost, high value primary care, and thanks to both investments from the Recovery Act and ongoing investments through the Affordable Care Act, the footprint of health centers is spreading, increasing services and increasing clients. So we're now going to be able to serve about 31 million people, including yourself. And I think they are an incredibly important, play an incredibly important role, particularly in underserved communities. In terms of the home visiting program, again, lots of very strong scientific evidence that makes a huge difference to help give parents the tools to be the best parent they can be, that having a professional encounter with young parents is often extremely beneficial, a pathway to an early, strong start in learning. So the President's budget, as you say, both increases the voluntary home visiting program as well as continues to expand the footprint, both new sites and additional services at sites for the for the Community Health Center program.
Have not been automatic, but our experiences have come as a result of a large number of people believing in the program, believing that it will work, and then working to make sure that it does work. So I thank you very much. And
Well,
go back.
I don't think it comes as a surprise that in states where the governor is very supportive, where there are delegation members, providers, others reaching out, there is a more positive experience than Congressman Doggett has mentioned Texas, where there are not only barriers, but significant laws that have been passed, which make it very difficult for a lot of the outreach people to even do the job they were contemplated to do.
All right, thank you. Mr. T. Berry.
Madam Secretary, Mr. Young submitted for the record this report, The Irony of Obamacare Making Inequality Worse. I'd like to read the conclusion, which says, for 2 years, labor unions, employer partners have patiently explained to the Obama administration and Congress the potential damage that the ACA poses to these unique, successful nonprofit plans. Having already made efforts to accommodate businesses, churches, congressional staff, it's ironic the administration is now highlighting issues of economic inequality without acting to preserve health plans that have been achieving the goals of ACA for decades. Without a smart fix, the ACA will heighten the inequality that the administration seeks to reduce. We take seriously the promise that if you like your health plan, you can keep it, period. United Here members like their health care plans. United Here members plans are ready to compete with the corporate giants of healthcare industry if Washington will simply create a level playing field. There were 3 articles in local papers in my district I'd like to submit for the record, Mr. Chairman, that highlight this very issue. The Mansfield Journal reported on Monday that only 6 of the Obamacare exchange plans in Richland County include the only hospital in the county, Med Central, in-network. The Marion Star reported on Monday only 6 of the 26 Obamacare plans in Marion County have Marion General Hospital, again, the only hospital in Marion County in network. And finally, the Newark Advocate reported only 6 of the 26 Obamacare exchange plans in Licking County consider the only hospital in Licking County, Licking Memorial, to be in network. That means that 3/4 of the exchange insurance plans in these counties don't give access to county residents to the only hospital and hundreds of doctors in network. And because many of my constituents now are facing the choice of being in network and having to travel out of the county, maybe 100 miles to a hospital, and are now losing doctors that they had. And these were people who had insurance and now have been forced to go into the exchanges, and in the county in which they reside, they can't even go to their hospital. This is a problem just beginning. We spoke to a lady in the office yesterday, a Central Ohioan, who wanted me to give you her name. Her name's Colleen. She had health care. Now she's one of the 4 million in the exchange, and she has a plan that she's paying more for, that she doesn't like, that she actually lost her doctor. She liked what she had, she couldn't keep it, and now she can't even keep the doctor that she had. So the articles aren't misinformation or disinformation. The union report, not supportive of Republicans, by the way, is not disinformation, and yet there seems to be a disinformation campaign within the administration that this is all just make-believe. Madam Secretary, please help us reassure our constituents that the administration is going to deal with the reality that's hitting the ground, and that's people are losing their doctor, and now they're losing their hospital.
All right, thank you. Mr. Schock.
Thank you, Mr. Chairman. Welcome, Madam Secretary. Yesterday, the House of Representatives passed a bill dealing with the Affordable Care Act that clarifies the religious exemption clause for a small segment of the population who, on their annual tax return, will have to basically verify that their religious conscience prohibits them from participating in traditional health care here in our country. This is modeled after a law that the state of Massachusetts put into effect. In the state of Massachusetts since 2006, only 6,000 residents have taken advantage of it, primarily Christian Scientists and others. The bill passed out of the House yesterday unanimously. It's now headed to the Senate, where it enjoys bipartisan support. Senators Ayotte, Schatz, Durbin, Bernie Sanders. I'm just wondering if you could speak to whether or not you support this clarification in the religious exemption clause.
Congressman, I haven't read the language, but I will take a strong look at it, and I do know that it passed yesterday, but I haven't read the bill.
Will you get back to us with your opinion on it? Okay, thank you. Second question has to do with the administration's change in, or HHS's change in how you're handling the appeals process for Medicare providers. The Office of Medicare Hearings and Appeals has recently taken the unprecedented and unorthodox step in no longer accepting Medicare appeals for processing at the administrative law judge level. Obviously, I'm concerned about the current health care providers and current seniors who could be denied reimbursement, what effect that will have downstream, if you will, if they're not allowed their due process. And then, of course, if we fast forward into the implementation of the Affordable Care Act, if we set the precedent that HHS says we're not going to allow for due process for current Medicare recipients, one would then assume perhaps that would be a practice that the agency would do for folks on the ACA. Are you working through that? Do you see the administration standing firm and not allowing due process on the appeals?
Congressman, this is a major problem and issue, and I know that our head of the Office of Medicare Appeals has been here on the Hill briefing in a bipartisan nature, both the House and the Senate, just on what has happened over the last couple of years. It's my understanding, and I don't want to misspeak, but I'll tell you what my understanding is, and if it's incorrect, I will correct it immediately, that their initial decision to suspend hearings was not for beneficiaries, but for hospitals and providers. So they were very concerned that beneficiaries not get caught in this
Right.
huge queue and go to the back of the line. In the meantime, they are looking at the whole array of systems which could alleviate the queue. The volume has about tripled over the last couple of years. We need to do some system changes. We need to work carefully with Congress, because the last thing we want to do is have anybody give up their due process rights.
All right, thank you. Mr. Rangel.
Thank you. Madam Secretary, I am convinced that when the final pages of history are written, that your name will be included among the courageous pioneers that have brought health care to all Americans. There seems to be some concern about the delay in the program. Do you recall when last we had a program for the nation where all people would have access to health care?
No, sir.
So that's since the beginning of the Republic.
Yes.
And so this is the first time. When we had Social Security, were there delays in legislation necessary to improve it?
Well, I would say both Social Security and Medicare certainly has transformed over time since they've been in
So I
place.
understand that the enrollments are going up and that people, young and old, are applying.
That's correct. We put out information yesterday that as of the end of February, about 4.2 million people had enrolled. In the private market, another almost 9 million have qualified to be Medicaid eligible, and 3 million young adults got their coverage earlier in the program thanks to their parents' plan.
And that's young and healthier people to bring the balance
Yes, sir.
that we need. Is there any indication that they are all Democrats?
We don't have that information currently.
Was there any reason to believe that the Republicans are not in need of health insurance, so they don't have preconditions, so that they all are insured? Is any evidence that Republicans will not receive the benefits of the Affordable Care Act?
No, sir.
Well, it's in the 50 attempts to derail or to repeal the Affordable Care Act, which has passed the House, the Senate, and approved by the Supreme Court. Is there any indication from the President, if by some stretch of our imagination the repeal goes through the Senate, as to what the President would be inclined to do?
I think he has indicated he would veto repeal of the act.
And so, has there been any suggestions then from the Republican leadership, since this is the law of the land and is universal and bipartisan as relates to the beneficiary, have there been any suggestions from the Republicans as to how we can improve upon this bill, that is the provisions to provide health care for everyone? Have they suggested to you anything that makes sense?
Well, there have been a number of conversations, and I would say some productive conversations. Unfortunately, I think the suggestions of how to improve are often tied to suggestions of how to
Madam
repeal.
Secretary.
All right, time has expired, and I would just say
that's a terrible
there have
thing,
been
because I wanted to
suggestions.
congratulate the chair, and I will insist on congratulating him as being a part of that Republican Party that has tried to be constructive on legislation, and I thank you.
Well, thank
for
you.
your
There's
courage.
always time for that. We are just down to we're just down to Mr. Levin and myself, and I just want to return to this issue about how many individuals have paid their first month's premiums. And I realize that you have repeatedly said under questioning that you don't have that information yet. But I just want to make the point that we're 2 weeks away from the end of the 6-month open enrollment. And, I know there's been, HHS has spent $2 billion building these exchanges, and your own budget document states, and I quote, CMS administers the insurance affordability programs on behalf of all marketplaces. This process involves receiving enrollment information from marketplaces, including the level of APTC selected to calculate and distribute monthly aggregate payments to issuers for APTC and CSR owed, end quote. But given all the time and the critical need that your own department has for this basic information, I think it's just absolutely critical that we find a way to get this information. And there are reports that up to 20% of individuals who've selected plans have not actually paid their premiums. And I don't know if this is in line what you're seeing. Do you have any information along that line about, is the 20% in line with what you have been finding out?
I think, again, Mr. Chairman, the 20% number came from insurance companies, if I recall, about the first of the year, where they were heartened by the fact that even though the deadline for payment of the first month's premium, and many people, if you will, enrolled for the first time in December, we've had kind of 3 months of strong enrollment, they were heartened by the fact that they had about an 80% payment rate. But again, that did not come from us. We will eventually, when the fully automated financial system is in place, have that information and be glad to share it with the committee in real-time basis. We just don't have it right now.
Well, and I think there's such an interest in this for one reason, is that we know that at least one, and that you've made at least one, you're about to make the second payment to insurers for the premium tax credits and cost-sharing subsidies.
Yes,
and so these payments reflect what insurers are telling you about how many people have paid their premiums.
They are an aggregate number based on only those customers who would be qualified for either cost-sharing or APTC, and that is not at all the entire look of the marketplace. So we don't even have any information at this point, even in aggregate. We don't have individual information about the group that is premium tax credit, and the insurance companies, to get paid month 2, just restated the first month as an indication that they did not have the full information. So we're getting aggregate data about a portion of the marketplace and not individual data about customers.
Well, they are not, unless they've paid their first month's premium, they can't get a premium tax credit.
That's correct.
And so obviously that's in the jurisdiction of this committee. We're very interested to make sure that that's being used.
And we are too. And we will be truing up with insurance companies a person at a time. We just don't have that at this particular
Have you
time.
asked the insurers for this information?
We are working, Mr. Chairman, on the automated system, which at the end of the day, the 834, which is the process by which we send to the insurance company from the website Chairman Camp's name, who wants to enroll in Blue Cross of Michigan, and there will be a process where they will send back the confirmed 834 that Chairman Camp paid his premium, and that will be the end of the loop. Currently, that part of the process is not in place.
Is there a coordination between the agencies on this? Because obviously some of this is administered between IRS and Treasury. Are you coordinating? I know in answer to some other questions you mentioned that some of this is involving more than one agency. So are IRS and Treasury?
Well, as most bills, Treasury basically pays the bills, and they pay them based on a system of our presenting them with information, much the way Medicare bills are paid.
All right. Mr. Levin, and then we'll conclude.
Thank you. Well, welcome. I just want to ask that there be entered into the record, Mr. Chairman, 3 documents relating to the Medicare Advantage rates, one from the Secretary to the Speaker, one for an article from the New York Times, and one letter from beneficiary groups.
Without objection, they'll be entered into the record.
And also ask that the CBO table on 4015 that will be coming up in the next couple of days with your amendment showing that about 13 million people would be uninsured. I ask that be in the record.
Without objection as well.
Thank you.
Well, with that, again, thank you for your time this morning, and
Yes.
Appreciate that. With that, this hearing is now adjourned.
I'm sure there are. The most surprising thing is that 8 passes, whatever that is, and the GA, whatever the GAO.
Oh, I got that information. Sorry.
What is it?
The Sessions requested a GAO study of the cost of the Affordable Care Act if you took out all the taxes and other cost-saving measures.
Okay.